Good evening to everyone. I present to you the corrections of these questions of surgery given to you by Excellence Academy, the reference bilingual group specialized in mentorship, orientation, and preparation of the residency concours in Cameroon and abroad. The instructions. Each question or statement below is followed by several propositions. Select the statement that best answers the question or best completes the statement. 1. Intestinal obstruction of the elderly leads to the suspicion of the following etiologies except one. Which one? A. Obstruction of the colon due to cancer. B. Hirschsprung's disease. C. Obstruction of the small intestines by biliary ileus. D. Ogilvie syndrome. E. Pseudo obstruction of the colon by a fecaloma. So the best answer here is B. We need to know that intestinal obstruction in elderly patients is usually caused by acquired conditions, whereas Hirschsprung's disease is a congenital disorder due to the absence of ganglion cells in the mesenteric plexus. This condition typically manifests in infancy and is rarely diagnosed in elderly individuals. As of what concerns option A, colonic obstruction due to cancer. It is common in older adults due to the high prevalence of colorectal cancer. Option C, small bowel obstruction due to gallstone ileus or biliary ileus. So the best term here is gallstone ileus. So this is caused by biliodigestive fistula and the impaction of a gallstone in the intestine. Option D, Ogilvie's syndrome is an acute functional colonic pseudo-obstruction often linked to an underlying condition. Option E, colonic pseudo-obstruction of the colon by a fecaloma. It is frequent in elderly patients with chronic constipation. Question number 2. Which of the following statements is true in patients with upper gastrointestinal bleeding? A. The bleeding point is located frequently beyond the ligament of threat. B. Angiodysplastic lesions are a common cause. C. The patients always present with hematemesis. D. Diagnostic endoscopy is best done within the first 24 hours. E. Selective mesenteric angiography is the key diagnostic step. So for this question 2, we can see rightly that the correct answer is D. Diagnostic endoscopy is best done within the first 24 hours. We need to recall that upper gastrointestinal endoscopy is the gold standard for diagnosing and managing upper GI bleeding. It should be performed within the first 24 hours to identify the bleeding source and provide endoscopic treatment if necessary. Option A tells us about the bleeding site, which is frequently located beyond the ligament of threat. That is false. Upper GI bleeding is defined as bleeding proximal to the ligament of threat, that is located either at the level of the esophagus, the stomach, or the duodenum before the ligament of threat. Option B talks about angiodysplastic lesions, says angiodysplastic lesions are the most common or are a common cause. So that is false. The most frequent causes of GI bleeding are peptic ulcer disease and ruptured esophageal varices in cirrhotic patients. Option C talks about patients always present with hematemesis. That is false. Upper GI bleeding can also present with melena without hematemesis. Option E, selective mesenteric angiography is the key diagnostic step. That is false. Angiography is mainly used in cases of severe active bleeding that cannot be managed with endoscopy or for therapeutic embolization. Question 3. Which of the following statements relate to peptic ulcer disease? A. Ulcers are most reliably detected by a barium meal. B. Pyloric stenosis is the least frequent complication. C. Elective surgery is usually required. D. A drainage procedure is not always required after truncal vagotomy. E. Radiological evidence of subdiaphragmatic gas is always present after peptic ulcer perforation. The best answer here is the option D. A drainage procedure is not always required after truncal vagotomy. We need to recall that truncal vagotomy, also known as complete vagus nerve transection, reduces gastric acid secretion by decreasing acetylcholine stimulation. However, it can slow gastric emptying, sometimes requiring a drainage procedure such as pyloroplasty or gastroenterostomy. Nevertheless, drainage is not always necessary, especially with modern techniques like selective vagotomy. Option A talks about ulcers, tells us that ulcers are reliably detected by a barium meal study. This is false. We need to know that while a barium meal study can detect some ulcers, upper GI endoscopy is more reliable for diagnosis and allows for biopsies. Option B tells us, says pyloric stenosis is the least frequent or common complication. That is false. Pyloric stenosis can occur in chronic peptic ulcer disease. We need to know that the least common complication in peptic ulcer disease is instead gastroduodenal fistula. Option C, elective surgery is usually necessary or required. That is false. The first line treatment involves proton pump inhibitors and Helicobacter pylori eradication if present. Surgery is reserved for severe complications like perforation, massive bleeding, and severe obstruction. Option E, radiological evidence of subdiaphragmatic free air is always present after peptic ulcer perforation. That is false. Free air under the diaphragm is a classic sign of perforation, but is not always visible, especially if the perforation is contained or in immunocompromised patients. Question 4. A 48-year-old diabetic patient has been admitted with diabetic ketoacidosis. On examination, there is an erythematous bulgy area on the left foot over a small ulcer, which is likely to cause the diabetic ketoacidosis. What is the management after resuscitating the patient? A. Ultrasound scan to look for collection. B. CT scan to assess the bones and look for collection. C. Ask for surgical consultation with a view to surgery. D. Magnetic resonance angiogram to assess the soft tissues. E. Plain foot X-ray to look for osteomyelitis. So we can see there, the most logical correct answer is option C. It is proper here to ask for surgical consultation with a view to surgery. Here we need to know that diabetic patients, so in particular this diabetic patient presents with diabetic ketoacidosis, which is likely triggered by a severe foot infection with a suspected abscess, given the presence of the erythematous bulgy area. So in this scenario, urgent surgical evaluation and possible drainage are necessary to prevent progression to severe complications such as necrotizing fasciitis or sepsis. Option A talks about ultrasound scan to look for collection. So that is not a priority. While ultrasound scan detect fluid collections, it does not replace surgical exploration in cases of severe infection. Option B, CT scan to assess the bones and look for collection. That is not the initial priority. Although a CT scan can help detect osteomyelitis or deep collections, it should not delay urgent surgical drainage. Option D, magnetic resonance angiography to assess the soft tissues. This is not appropriate in an emergency as it is mainly useful for evaluating vascularization in cases of critical limb ischemia, which is not the immediate concern here. Option E, plain foot X-ray to look for osteomyelitis. It is not a priority. While osteomyelitis is a common complication of diabetic foot infections, initial management should focus on surgical drainage and antibiotic therapy. X-rays can be performed later if needed. Question 5. A 45-year-old man presents to the emergency department with a history of coffee ground colored vomiting. He also reports that for 2 days his stool has appeared darker than usual. Which of the following gives the most sensitive guide to the severity of his gastrointestinal hemorrhage? A. Hemoglobin level. B. Systolic blood pressure. C. Pulse rate. D. Volume of vomitus or melena. And E. Line and standing blood pressure. The best answer here is E. Line and standing blood pressure. We need to know that the best indicator for the severity of an acute GI bleeding is the presence of orthostatic hypotension, which reflects significant hypovolemia. So a drop in the systolic BP greater than or equal to 20 millimeters of mercury, or an increase in heart rate greater than or equal to 30 beats per minute when moving from a supine to a standing position indicates a blood loss of at least 15 to 20% of total blood volume. As for what concerns the hemoglobin level, it is unreliable in the acute phase as hemoglobin levels may remain normal initially due to hemo concentration. It usually decreases after fluid resuscitation. After fluid resuscitation dilutes the blood. Option B, systolic blood pressure. It is unuseful. The systolic blood pressure can be useful, but it is less sensitive since compensatory mechanisms like vasoconstriction can maintain blood pressure until significant blood loss occurs. Option 3, the pulse rate, which we can equally call the heart rate. It is a helpful indicator, but hypovolemia may be masked by sympathetic compensation, delaying tachycardia or increase in the pulse rate. Option D, volume of vomitus or melena. This is not reliable as the severity of a GI bleed depends not only on visible blood loss but also on tissue perfusion and hemodynamic response. Thus, measuring blood pressure in both supine or lying and standing positions remain the most sensitive method for assessing the severity of an acute gastrointestinal bleed. So thank you very much for your attention. Consider subscribing and clicking on the notification for quick updates of new videos. And let's always keep in mind that discipline and consistency constitute the sole bridge between our set goals and their achievement. Thank you.